couple of points I should mention before going on is that in the last talk I focused it on particular areas that, looking at your literature, I see as difficult spots. And I hope to return in the third lecture to talk a little bit about why those things happen. But I see that there are many papers without gold standards, without independent gold standards, and also those that do, and some have really good gold standards, end up with mostly patients with disease, which puts you in a very difficult spot. It means that you get that really good idea of what sensitivity is without a very good idea at all of what specificity is, which means that the uncertainty propagates from the specificity index to the sensitivity index. And so I focused the way I have for those reasons. But I think that there's more to say about the issues of gold standard, particularly in situations where the imaging itself, without a great deal of trouble, is the thing that gives you the best idea of what's going on in the patient. But pushing on to my second topic, and this is kind of why I do what I do. I mean, the whole theory of signal detectability is, for me, like probably most of you, kind of a necessary evil. I am interested in understanding why errors happen in radiology by understanding why they happen. I got my start mostly from people like Tony Franken and Hal Kundell. Hal Kundell is really, Hal Kundell in radiology is sort of the father of this kind of research. Our own lab started close to 30 years ago. It included me, Tony Franken, who was chair at Iowa for 15 years and has been my close collaborator most of the time until he temporarily retired and was quickly brought back as an interim chair. He's the Centennial Fellow of the RSNA. He has the gold medal from Society of Pediatric Radiology, Association of University Radiologists, and lots of others. Very smart guy. Don Dorfman is, he and I worked together on ROC methods for 20 years. Very important in my background. We work with lots of radiologists because this is where we get images. Images for our studies come from the reading room, from a variety of disciplines. We've got skeletal radiologists there, chest radiologists, abdominal imagers. I've got a lot of other people who, in the lab that I depend on. Medical physicist. If I had more time, I'd tell you about all of the innovations and progress that Steve Hillis has made on the statistics of ROC. Kevin Schartz, who is not only an experimental psychologist, but as a computer scientist develops software that allows the experiments to be run and creates a technology for running experiments that I think of as one of the crucial elements in progress to the future. One of the problems that many people have is that I say, well, it'd be good if you had 10, 20 readers, expert readers, and they say, oh yeah, sure. Kevin's software packages experiments so that they can be transmitted to other places so that you can collect data from multiple sites and have expert readers. It makes a lot of experiments possible that wouldn't be otherwise. And of course, Elizabeth Krapinski, my longtime collaborator from Arizona, she and I do studies together on fatigue effects and what that does to reading. This is a good quote from Cal Nodine. Missing a substantial finding on a radiograph is an event that escapes few radiologists during their professional careers, and when these errors are pointed out, most are astonished that they did not see what now in retrospect seems obvious to them. Jim Pochin is kind of an old-timer, but has been interested in perception in radiology a long time. His point is that for all of the effort that we put into our equipment, the variability among observers overwhelms some of these differences in technology. And of course, you would think that there might be some help for improving performance from neuroscience, psychology, and related fields. Unfortunately, there's not enough of an understanding of the fundamentals of pattern recognition within these disciplines to be of much help. So what we're left with is kind of a human factors, folksy approach to studying error-prone situations in radiology. The notion being that if we can understand why errors happen, then we can maybe prevent them. Now, I've studied a variety of these error-prone situations, most of which I'm not going to tell you about. I spent 10 years studying the impact of clinical history on detection in radiographs. I had a 15-year war with Harvard about what the nature of that effect was. Now, I could tell you all about that, but problem is, it wouldn't do you guys any good. Because as I understand it, you're mostly both the radiologist and the surgeon. So when I talk about, the ability to communicate clinical information from the radiology or from the ordering physician to the radiologist and the impact that has, that's pretty much circumvented by your unique situation. Satisfaction of search. Satisfaction of search is a very common class of error. It happens when there's more than one disease process or more than one abnormality present in the imaging study. What's the hardest abnormality to find? Why, it's the second one, or maybe the third. Let's have an example. You guys are probably pretty good chest radiologists, and so when I show you this picture of a shoulder, you can probably find the abnormality. Anybody? No? Yes, there are two. The acromion has got a fracture, and we also have a fracture of the rib. Talking about satisfaction of search actually came from radiologists. First Tuddenham and later Smith has a lovely little book from 1967 in which he coined the term satisfaction of search. And the original definition many people believe that satisfaction of search has to do with discontinuing your search for abnormalities. It doesn't. The actual definition had more to do with expectation. It said, if you, once your quest for meaning, a meaningful interpretation of the study is found and satisfied, you're unlikely to find other interpretations. Now, of course, well, okay, Smith. He reviewed 437 cases that happened in his practice for 2 years, and he had 209 under-reading cases, which means that they missed the abnormality. And of those, 28 he attributed to satisfaction of search, which would be 13% of the misses and 6% of all errors. We did a study later where we found a somewhat higher fraction. Now, of course, all of these studies from the clinic, they're really kind of guesswork. They're guesswork because, one, you never tested the detection of the abnormality that whose detection you think has changed with the presence of the other lesion. You couldn't take that other lesion away and find out whether it could have been detected if the other lesion wasn't there. So it's really hard to say. Plus, there's usually something else going on. In radiology, there's always something else going on. There are always people interrupting you. There are always long hours to be worked. The problem is that in the clinic, you really don't have any way of attributing a specific cause for an error because you don't have the appropriate control conditions. So satisfaction of search errors attributed to satisfaction of search are very common. 90% of the errors in emergency medicine are thought to be owing to satisfaction of search, also known as premature closure. Now, we've been working on satisfaction of search errors for some time. We've had 22 years of support from the NIH to do so, and that's led us to do quite a few experiments. We've done 4 types: receiver operating characteristic studies of the kind that we talked about last time. We perform analysis of response times that gets us some information about the nature of their search and how long they're willing to engage in it. We do gaze dwell time studies, in other words, eye tracking, which is an arduous technology, but which gives you information about where gaze actually falls that can't be had from any other place. We've also studied interventions to prevent satisfaction of search errors. And there they are. Now, most of these studies that I'm going to be sort of breezing through here in the next few minutes come from radiography. We began studying advanced imaging we've been doing it maybe 8 or 9 years. And the complexities in doing so are enormous. So mostly what I'm going to be focusing on are the radiographic studies, but maybe we'll touch on the CT studies as well. I'm going to give you the answer the answer as far as I know it right away, because, you know, you've been sitting here a long time, and I'm not going to hold that out. Basically, in chest and in trauma radiology, satisfaction of search doesn't happen because you didn't look at the abnormalities, or that you stopped reading because you found something and said, oh, well, I got it. However, there are situations, particularly involving contrast media, that produce changes in your global search, in which you basically focus on what the contrast shows you, and the rest of the image becomes more or less invisible. Invisible because you never put your eye there. Okay, so how do we do these studies? Well, I told you before that there was trouble in trying to attribute errors that happen in the clinic to satisfaction of search because you didn't have a control condition. In this chest X-ray, we have pointed out by the arrows, the image on the left, let's focus on, there's a pneumothorax. And it is evident as a line and an area of greater darkness in the top of the image. Now, what we've done is photographically placed a pulmonary nodule in the lower right chest. Can you see that? So now we're in a position to test how well you find the pneumothorax with and without the added nodule. Part of our thinking here is that nodules tend to be found before other abnormalities, so we could find out whether finding the nodule first had an effect on detecting the pneumothorax. Now, we also play this game when there's nothing there, when there's no abnormality in the image, because we have to collect cases, normal cases. If we don't do that, we can't play the ROC game. Okay, here we have a chest, the original and an altered version, and we have the lateral. And the lateral is shown with either version of those two. This, what we're looking at with the white arrows, is called the spine sign. And it has to do with expecting changes in luminance because the vertebrae are getting bigger as you go, and so you're expecting this gradient. And if you don't see it, the reason is that you've got pneumonia. So now we introduce our nodule, and we test detection of the spine sign with and without. And here's our answer. Here's our answer with contaminated binormal model and with, oh, you're going to love this, the decontaminated binormal model. That's another one of my inventions. But basically, it's a location-specific ROC curve. When we look at the time course of responses, we find that there's no difference, well, very little difference, in when people stop looking, regardless of how many abnormalities we put on there. So the notion that you just find something and say, I'm done, is just not true. We also found that we were right. The nodules tend to be found first, followed by natives, followed by false positives. Interesting, huh? Turns out that false positives do tend to happen late in the reading interval. And one of the differences between novices and experts is that novices tend to read longer. And they read to the point where they're making more false positives than true positives. Experts don't do that. They stop before the number of true positives is outnumbered by false positives. We did the experiment again, and this time we said, well, what if we give different clinical histories that make people think that they're supposed to be looking for nodules, or any of these other diverse abnormalities that we're measuring. And turns out when we do that, here we're fitting another kind of, we're fitting a gamma distribution to the time course information. With no information, nodules get found first, followed by natives, followed by false positives. If you prompt natives, they happen first. If you prompt nodules, they happen even quicker than they did before. And prompting the natives not only brings them earlier in search, but it tends to it tends to eliminate the satisfaction of search effect. Yeah, I know, I look good. This is typical eye tracker that's been used in radiology research. I used this device, well, there's a lot more to it. I used this device for 8 or 10 years. It has many problems. The problems are not related to its accuracy. Basically, it looks at your eye. It has a little camera up here, and it goes through a half-silvered mirror, looks at your eye, gets reflections. It has a little coil on it that is a magnetic coil, and you set up a big magnetic field so you know where the head is, you know where the image is. It's complicated. This thing gives people headaches. It gives people headaches within about half an hour, which means there's only so much data that you can collect, which is one of its problems. However, it is highly accurate. The accuracies we were able to achieve are on the order of a half to a third of a degree of visual angle. Okay, well, what does a record from this device look like? You get clusters of fixations, and ha-ha, that person's right on our nodule. Hal Kundell and Cal Nodine developed a classification scheme based on time on parts of the image. In processing this kind of information, there's a lot of autocorrelation going on. You take the data and basically you're clumping it, and you're clumping it to find fixations. And then you clump it some more and get sort of little clusters where people's eyes are jittering, but they're looking at the same thing. And by looking at these clusters of fixations, you get a crude measure of attention. You get how much time they spent on each location within the image. And based on this kind of data, Kundell and Nodine developed a classification scheme where they said, we got errors that are produced by faulty scanning. In other words, you didn't ever look there. You never got any dwell time close enough to the lesion that we think that you scanned it well enough. And they backed that thing about close enough. How close do you need to be? In their case, it was 2.5 degrees visual angle, but they backed that up with tachistoscopic experiments, which are experiments where involving brief presentation. So you can do scanning here. You can figure out whether the image was sampled in that region. They also talk about decision-making error. And decision-making error happens when you look at the region containing the abnormality or close to it for long enough that we get the idea that you've seen something and you're thinking about reporting it, but you didn't. Now, in their case, they did all of their work with pulmonary nodules. A lot of research in radiology gets done that way because it's the abnormality that we could typically manipulate. And for them, a decision error happened after you'd been looking at the abnormality for a second. In between, we have recognition errors. In other words, it's between the two. You looked at the abnormality, you put your eye there, you dwelled there long enough that we know that you scanned it, but you never stopped for long enough that we got the idea that you were preparing to make a decision. Now, of course, these are definitions. There's nothing beyond that there. Okay, what did we find out? Well, the first thing we found out was that these errors didn't happen because of scanning. There was always time on the abnormality. In fact, a lot of the time, the times on the native abnormalities that we were testing, like the pneumothorax, like the spine sign, like the thing that we didn't manipulate, they were long. So that sort of looked like decision-making error. Now, of course, a problem with the Kundell methodology is that it really only works super well for nodules. So we did some further experiments, which I'm not going to tell you about, but which ruled out the decision-making errors. Basically, we come up with pattern recognition as the culprit. In my little view of my graph of our experiments over the years, I listed chest radiology, skeletal radiology, and contrast studies. So this is the slide that tells me I'm about to start talking about SOS studies in skeletal radiology with my good friend George L. Curry. We studied satisfaction of search by working with patients that have suffered multiple trauma. If you are in a car accident or if you fall off of something and you go to the emergency room, the likelihood is pretty good that you're going to end up with lots of radiographs. You're going to have radiographs of all of the potentially injured parts of your body. And they're going to be presented on a big panel. Well, not so much anymore. Sometimes. In the old days, they would have panels that were 8 panels wide. That's twice as wide as the usual film alternator in the reading room dedicated to trauma. Well, we decided this would be a good place to study satisfaction of search. We could put, here's a standard 4-film panel. We could put a film with a subtle fracture in one place, and we could do it for 2 conditions. We could put some normal films in here, and normal films, as we know, are a good place to collect false positive responses for ROC analysis. And then we could, in one case, have no fracture in our first film in the bank, and then we could add a fracture. Ha-ha. So now we're in a place to get some true positives and some false positives. And here, the manipulation that gives us SOS, we're not going to score that, but it's what may change the rest of it. So that's our plan for experiments. Here's an actual example of a case. So we limited ourselves in this to 3 or 4 exams. This case, there's a pelvis, a leg, a knee, and on the knee there's a fracture, and that's the fracture that we are going to test the detectability of. Now, to create our SOS condition, all we have to do is replace our hip with another hip that's similar, but which indeed has a fracture in it. So we added in our distractor fracture. We used a technique that would allow us to measure time so that it was like the last experiment. We, as you can see, we're simulating patients here because not all of that, obviously the pelvis that we're switching didn't come from the same patient. And 46 of these had test fractures. In all, we showed 215 radiographs to 10 radiologists, and we got some curves. Now this experiment happened in 1994. Can anybody see anything wrong with these curves? Right. Based on our knowledge from our first lecture, we know that this is a little dicey. And yes, all of my early experiments had to be reanalyzed and republished with methods that don't give hooks. I had to do it. The paper in the New England Journal didn't have to do it, but I had to do it. Then after we'd done that, we decided to do some eye tracking. And this was very complicated to do because we wanted to maintain our half a degree visual angle of accuracy to get our classification system to work, but we had a huge area now to work with, and we actually had to map the magnetic space to get it to work. Once again, we found that errors were not based on faulty scanning. People looked at the fractures that they missed. Oh, look, there I am, long ago, and here's when the technology changed. Notice the frown on my face. That's because all of my case samples had to be discarded, and I had to collect all new images so that I could put them on these wonderful monitors. And in the process of studying SOS and more severe images, that's when we started getting into CT. Because your really serious injuries, some of the really serious injuries that you get are broken necks. And those cause quadriplegia. And those, at the time that we were beginning our studies, they were just converting from radiography to high-resolution CT. So we had to make a change. Here's a serious fracture on CT, and the same fracture can be viewed on radiography. Here's a not-so-serious fracture presented on radiography, and here's one of our test fractures on a foot. And so we did the same experiment. I was going to jump over this, wasn't I? It's just so compelling to me. So here we have a foot, we've got a chest, we've got a pelvis. Notice that for the severe fracture, we then have to include a CT image. Everything gets a little bit more complex. These are what the displays look like. You get little thumbnails, and then you bring up the studies one at a time. Same kind of thing. This is our result with minor fractures. These are medium serious fractures. They're not so hard to see, but they cause satisfaction of search on other fractures. Interestingly, the more severe injuries did not. Now this goes against the conventional wisdom. This goes against what radiologists will tell you about why they miss fractures. If you're going to do an M&M conference, everybody loves to bring an SOS case, particularly one with a serious injury. What could be better than bringing in a case where you can say, see, I missed this little tiny fracture over here because I was busy saving the patient's life. Our experiments don't give us that answer. Now, other things could be going on. I'd love to repeat these experiments when people are tired or when they're interrupted. And we've also done this same experiment with all radiographs, so that we know that it's not based on simply the mode of presentation. Okay, so finally here we are at contrast studies. We're going to play the same game. It's another opportunity to study satisfaction of search, because when people are going to have studies made of their abdomen using contrast, urinary system, digestive system, they usually do a scout film that's a plain radiograph beforehand in order to see if there's anything going on that they can see. In this case, we have Paget's disease, evident in the hip. And here we have intercolitis showing partial small bowel obstruction. And so we could do cases that way. Here we have a blastic lesion present in both cases. Here we have another contrast study, and it looks like, I think maybe the last one was ischemia, and this one's obstruction. Here we have a rib fracture, and I'm not sure, but I think maybe we've got stones in here. And what did we find? Well, this was a new finding for us. This is different than we've had before. There was, first of all, no difference in the ROC curves, but something is going on. The dots here have to do with the magnitude of certainty. The more certain, the bigger the dot. We had 10 radiologists, so each of these 4 panels has 10 columns and 21 or 22 rows for the number of normal cases or abnormal cases. And here we are in the plain film study. Now this is for detection of all those diverse abnormalities that were not demonstrated by contrast. Well, surprise, surprise, we're calling a lot more stuff when there's stuff there to call. But when we go to the contrast study, all of a sudden we're not calling so much. Not only that, we're not calling so much when there's nothing there to call. What does this mean? Well, it could be 2 things. One thing is, it could be that we've changed our threshold. We're not calling as much stuff because maybe we see stuff, but we think, I'm not going to call that because really I'm interested in the contrast. Or it could be that maybe you're not looking. So what we did was take our images and we mapped them for regions. Regions of contrast, regions of plain film abnormality, and everything else. And we plotted time looking at those regions. Now, on the plain film studies, if you do that, these lines are all kind of running together because you're looking everywhere. But when you put in the contrast, all of a sudden, all you're looking at is the contrast. So you focused all of your attention, all of your inspection on the region of the contrast. You never looked at the plain film regions, so you never made false positives and you never made true positives out there. Your attention has been captured by the contrast material. Well, sort of that's that's the story of our study of SOS in radiography. We are starting to do more and more studies of advanced imaging. And the big change here in radiography, or radiology, is that we're getting more and more and more images. And there's quite a few people in radiology worrying about workload for that reason. In 1995, for a CT study, there would be about 90 images. In 2008, there were more than 400. I'd tell you how much there are today, but it seems like it's changing from day to day. And it's not getting any less. This is a wonderful quote. If you don't remember anything else from this lecture, I hope you remember this quote. This is from Herbert Simon. What information consumes is rather obvious. It consumes the attention of its recipients. Hence, a wealth of information creates a poverty of attention and a need to allocate that attention efficiently among the overabundance of information sources that might consume it. How many people know who Herbert Simon is? Okay. In my field, I just have to think for a minute which field that is. He's a very famous guy. He won the Nobel Prize in Economics, and, you know, more medals than, you know, I can even remember. And he said, and he really hit it on the head here, working with CT images has changed the way we do our science. And I'm showing you this picture of this workstation for more than just, you know, the obvious reason of telling you, you know, technology changes. The software that we use to run these experiments is something that we crafted based on NIH software called ImageJ. Basically what it means is that once we create a case sample and enter it in with script information into this program, we can ship this experiment anywhere we want. What does it mean? It means we can collect samples as many as we can get people to do it. And each time we do that, we can, you know, if we double our sample size, we are going to really improve power. Most studies of technology evaluation in radiology get done with 4 or fewer radiologist readers. That's because for any particular subspecialty, you may only have 3 or 4 at your place. Now that is a major limitation on power, statistical power. If I can get a collaborator, not necessarily using our software, but somebody's software that may be around here, you can vastly improve your statistical power. When you're working with a sample of 4, getting to 8 is huge. Anyway, enough said. This software also allows us to track search. We can plot time on slice. We can watch as you progress through the case, because all of this stuff, you know, if you're looking at a chest radiograph, it's all going to be read in the axials, a stack of axial images, and just cineing through it under reader control. That means that we can see how long people spend in the ranges where we've put abnormalities. We have some other cool technology. One is that we now are beginning to get control over the presence or absence of the abnormalities present in our images. This is a kind of experimental control that if you want to do this kind of research, you have to have. We were very limited with radiographs because everything is superimposed. That means that manipulating anything is very difficult. The most you can do in that circumstance is add a pulmonary nodule. Why? Because you can image it outside the body and combine it photographically. But you can't change any of the structures. Now, taking the images apart tomographically means that we can put abnormalities where we want them. We can start out by being able to take them out and store them and then put them where we want. These are pulmonary nodules. That's what we started out trying to do. But pretty soon we began to realize that there were other things we could do as well, giving us opportunities to explore a much more diverse set of lesions in studying satisfaction of search, fatigue, and other things. We've even progressed to where we can work with MR brain images. Basically, we have a software suite that is available. I don't know if it would work for your images, but it allows us to map abnormalities, store them, remove them, insert them, and there's a subsection that allows you to test whether people can detect the manipulations that you've made to those images before you use them in experiments. Oh, here's the PET. There's not too much to see here other than the fact that we can do it. At present, we are engaged in a great many experiments in chest CT and abdominal CT in which we study multiple abnormalities, like here and here. And I'm going to show you some of the manipulations we've done just because I like to. These things tend to look like Photoshop images, but you have to appreciate that if we get rid of this liver lesion, we have to get rid of it in all of the slices. And we've done pulmonary embolism, thyroid nodule, aortic dissection, gallstones. Actually, we sort of got rid of the whole thing. Liver lesion, gallbladder abnormality. That little line there is not supposed to be there. Pancreatic calcifications. Difficult to do because it's diffuse. Tracheal mass. Let's see, hernia. Aha. This one we were rather proud of because you actually had to add back structure. And then, of course, we can manipulate nodules. You probably can appreciate the nodule that appears here or here. To do some of the experiments, we're actually even having to use artistry. This fracture here and here, in two cases, was actually drawn by a Photoshop-like program. It's not a direct simulation, but it's going to be what's required to be able to study satisfaction of search in trauma in the same CT exam. We've done about 3 major experiments and about to start some more. And the story here is a bit cloudy, and I'm not ready to tell it very far, but I can tell you a few things about it. One of the things is that it's hard to create experiments here because experimenters operate under very different conditions than readers. It's very difficult to decide what a subtle abnormality is and what's not, because it's easy to, CT is beautiful. It gives you a picture in a few slices that gives you a very clear picture of abnormality. But in judging subtlety, we tend to forget about the length of search through every place that didn't have the lesion in order to find that place that shows it clearly. Task effects are huge. In other words, the nature of what you're trying to find makes a huge difference as far as what you're actually going to find. Is that it? Let's see. Yeah. So we're done with another talk. I changed the title here to the applications of what I've already said to your field. We have to return to diagnostic truth. This quote from 82, this 82 book was sort of the handbook for doing this kind of research for radiology. It really set forth the methodology for this, the first really sound statement of it. The part of this that, 1982, okay. Sweats and Pickett, it's a little brown book. The cost of obtaining truth, such as histology, and time required, such as follow-up, must fit within the cost and time constraints of the study. That's really important. It's one thing to talk about what you can say scientifically, but if you get to the point where it's impractical to do the study, you haven't gained anything. Truth, let's face it, that's where acquiring the truth is the most expensive, time-consuming part of the study. It's the part that will stop you from doing it. And another thing that happens is that the stronger your evidence for truth, the fewer patients you're going to have, because they're not going to be, you're not going to have that same standard of truth available. Now this can limit your conclusions. Finally, a lot of what we're interested in going to more advanced technology is subtle disease. That's why we're doing it. We're trying to find the cancer earlier, which means that it's more subtle, which means that it's harder and harder to get the truth information. Imagine an experiment where you said, well, I'm going to have a standard based on the reading of all of the available imaging from 2 experts in the field. I can't do the histology, I can't do that's what I can do. But you say to yourself, well, I've got to make, we've got to have some standard so that's reliable. So I'm going to take my 2 readers, and I'm only going to include patients in my study that the 2 readers agree on what the disease is. So if they don't agree, I'm going to drop the case. I'll do the study on 2 readers agreeing. This study was done, of course. This was an early study of CT, and they found no difference in the modalities that they were both CT modalities, but they found no difference. And of course, when you understand what they did to get their truth, it made perfect sense. They dropped out all of the patients that the modalities are expected to differ on. This is an extremely common problem in dealing with advanced imaging. Sometimes it is very hard to get independent information that is either better or independent from the imaging that you've got, that you're trying to evaluate. This leaves us all in a difficult situation. It means for the researcher that you're going to end up doing studies other than the one that you want to do, other than that answers the question, is one technology better than the other in terms of diagnostic accuracy? Maybe you're reporting just, how many findings your modalities come up with. This one found more abnormal features than this one did, and we're going to assume that all of those features represent true disease. Fundamentally, it means that there's going to be a limitation on your science. But there's limitations for practitioners too. You're going to tend to be convinced by modalities that show you more features of anatomy that you know to be there. In other words, if you can visualize anatomy that you know is there, it's going to make you tend to believe that you're also going to be able to visualize pathology, but you're not really going to know whether that's going to lead to different decisions. And then there are trade-offs to be factored in, such as radiation dose. All I can really say is that practice decisions involve more than science. ROC, another take-home message. Do you really want to try this at home? No. If you're going to do ROC studies in a serious way, you should get help. And there's lots of it out there. There are first-rate people in particular areas. There are people at the FDA, particularly if I was going to do a study providing evidence to the FDA, boy, I would sure talk to those guys. If you're going to do multiple response data, there are people that specialize in that. So end of advice from ROC analysis. What about those errors? Identification of error in general is usually retrospective, and it includes hindsight bias. Monday morning quarterbacking, and it's usually, the nature of the bias is that there's better information available later than there is at the time the original exam was made. One of the things is that it's very common to get a later imaging study that shows more advanced disease at the location where it was missed before, so that a reader looking back on the earlier study, if they have already seen the better information, the later information, is going to be suffering from hindsight bias, and they are not going to know that they've got it, because humans are not very good at remembering the sources of information where they get stuff. They're going to read the exam and say, I saw it. How come that guy didn't see it? This is a very common factor in legal cases. My friend Tony Franken gave me this figure. Basically, he's saying, well, errors haven't changed that much. Technology has progressed, and the way it has progressed is that there's a lot of stuff that we couldn't diagnose before that we can now diagnose, but the rate of errors, false positives, false negatives, is still the same. Misdiagnosis accounts for 30% of malpractice suits in the United States. 1 in 5 radiologists is sued annually. By far, the most common kind of error is one where the radiologist simply doesn't see the abnormality. You probably think that this is satellite imaging, right? How many people see something there? 1. Think farm animal. Think moo. Everybody got it now? Everybody's got the cow, right? There's the nose. There's the eye, ear. Interesting thing about this is that once you've seen the cow, you can't not see the cow. In general, error in radiologists. Radiologists are pretty accurate, 90% plus. False negatives, misses outnumber false positives in ordinary clinical care, but screening that situation is reversed. All radiologists make occasional serious errors. Improvements have, there have been improvements by specializing, by education, doing descriptive research and QA activities. It's interesting, Wagner, Biden, and Campbell are people from the FDA. And their view was that, they are responsible for presiding over all these competitions between modalities and manufacturers, approving new technology. And they observe that what's the amount of improvement that's being fought over here may be on the order of 5% of the area under the ROC curve, which is plenty small enough for differences in humans to overwhelm those differences that we're getting. So improvements in reducing errors, improvements that reduce errors can make as big a difference as the machines. A problem here is that it's really hard to give advice. Why? Because human consciousness does not have access to the workings of visual perception, only its products. We get a very nicely organized world presented to us as objects and forms in space. We don't know how that happens. For this reason, psychology has never used introspection, at least for 80 years, as a way to seriously study perception. What that means is that while radiologists have experiences with error-prone situations that tell them about certain kinds of errors happening, they don't have any way to see into the neural processing involved in actually making those errors. What does that mean? That means that good advice is hard to come by. There are things that you can do. There are obvious things that you can do to improve your chances. Do the obvious things first. Dim the lights. Read like a radiologist. Get real squinty eyes. Induced myopia can be your friend. Certainly use the best displays you can lay hands on. DICOM calibrated often. By the way, spatial resolution is important, but contrast resolution is just as important. From the point of view of satisfaction of search, take a second look. Maybe even cover up the old findings. Look at it from a different task perspective. And surely, don't read when you're tired. Of course, in education, yes, be aware of the blind spots that are created by your technology and the limitations of technique, and continuous medical education. It may take years for the technology to sort itself out, and you have to keep on track with that. What does the exam cover? What is the standard of care? I'm telling you to have a plan for your attack, the nature of, know what you're going to do with the images that you've got. That's what task dependency is about. Is the plan consistent with the standard of care? That's where it all meets up with legal accountability. A standard of care is different for different people. Standard of care is what an expert witness is willing to say it is in a court of law. It's also what your scientific community says it is in print. Now, these things may be quite different, but that's why it's important to know what doing an exam means. In radiology, there is continuing discussion of charging for the interpretation of complicated imagery based on what you're trying to diagnose. The same set of images, you may have different charges depending upon whether you're trying to figure out the nature of heart disease or cancer. It matters. There is in the cone beam CT images that you've got an almost unlimited number of possible views that you could take. You have a situation in which you are focusing in order to use the power of the technique. And of course, accountability for errors changes with the technology itself. Now, I should tell you I'm not the best person to give you advice because I've spent most of my scientific career studying and often debunking the kinds of advice that people give. For example, checklists are supposed to be very helpful in making you not make errors. It's been recommended by leaders in radiology as a way to get rid of satisfaction of search errors. It doesn't work. Sorry, sorry. I could go on and on about that. Well, checklists are really good for novices. That was you, John, wasn't it? I've got a stooge in the audience. They're really good for novices. Experienced radiologists are split on the issue of checklists. Most think that they should use them, and they don't, because they slow them down and because most of their processing goes too fast for the checklist. It happens in parallel, but I've already said too much. CAD is, you would think that if you tip people off to the abnormality that is supposed to distract them, then the SOS effect would go away. It doesn't. How about a satisfaction of search effect in endodontic CT? I've observed from watching John that the approach seems to be to look at the transsagittal view of to actually make diagnoses, particularly if you're looking for infection. Here's an example. What a good example it is, too. Down here, we have the disrupted ligament. We have bone markings going away. And of course, in looking at, in getting to this view, we've taken a path. We've said, well, we've got to create an arch because we want to have a curved stack, and we'll create a kind of a scout view so that we can see what a panoramic radiograph would have given us. And look at this, we see some things that are kind of suspicious looking, and here too. And of course we've got these other things that are sort of tip-offs. We've got this, I think John called this a crummy root canal. He said it was a technical term. We know that from this line, blue to blue here, that we're going through this tooth to get our transsagittal view. And boy, has that done the job for us. And lo and behold, we can go through this tooth with the crummy root canal and look at what's happening out here. And lo and behold, we find, we don't find any evidence. There's no finding. It's okay. Wow, we're doing great. But how's the superior information going to help you with the other teeth? I mean, you've got so much information. You've used a strategy to get to the important information. What about all the other teeth? What about all the teeth that you didn't look at the transsagittal view? Are you going to look at all those teeth? Even the ones where you don't have clinical suspicion or suggestive findings in the more general view? I mean, that's where the better diagnostic information is. The question is, what are you responsible for? Are you responsible? When you make an exam like this, are you responsible for looking at the transsagittal view of all the teeth?
Depends how busy we are.
There you go. But there is also the possibility, given that, of being led down a garden path. The place where I want to end here is by saying that I don't know. I don't know if there's an SOS in your kind of imaging, but I see possibilities where it could happen. I'm a researcher, and so to know that answer, I'd have to do the studies. But it is something for you all to stay awake at night thinking about. Thanks a lot. Had a great time. Oh, good morning. Thank you. Thank you very much for having me. The first talk is mostly about ROC analysis and evaluation of diagnostic systems. In our laboratory at the University of Iowa, we work to improve diagnostic accuracy, and we do it in two ways. One way is to improve the imaging technology. Our specific role is to create methodologies for evaluation so that you are actually able to tell whether the new technology is in fact better than the old technology in terms of actually making diagnoses. The other approach we take is to study the interpretive process itself, trying to generally study error-prone situations identified by radiologists in order to discover something of the mechanics of the production of errors. And we'll get onto that a bit later. I need to introduce a few of my colleagues and mentors over the years. A lot of the work on signal detection theory comes from three individuals. Don Dorfman, who I worked with at Iowa for about 20 years. Dick Swenson from Harvard and later Pittsburgh. Don created the first methods for fitting ROC curves to data. Dick Swenson created a methodology for taking into account location information. This is my friend Charlie Metz from University of Chicago, who was instrumental in bringing ROC analysis to the general audience of radiologists. We use physical analysis to characterize diagnostic systems to a certain extent. If you knew exactly how you were going to detect signals, if you knew how the human visual system was going to pick up the information represented in an image, then you could measure that information and know how good a diagnostic system is. The problem is that we don't have a very good characterization of the primitive elements within the human visual system that recognize features, much less put them together into percepts that represent categories that we've learned. Now, we do know something from physical analysis. We know about spatial and contrast resolution. We know about temporal resolution. And all these are factors that there's a whole gang of people that work very hard to make right within the reading panels. Problem is that we don't know, while we have standards for these things that are mostly based on phantoms, we don't know what levels of these parameters are sufficient to ensure that any particular example of disease is going to be detected. So what we're left with is something that looks like this. And I'm sure you all have seen this kind of decision matrix before. This really is the most basic thing, though. What we're actually doing here is comparing what our test tells us with what we know to be true. Now, the hard part here is knowing to be true. It was recognized very early that if you're going to evaluate diagnostic systems, you need some standard of truth that goes beyond and does not depend on, is independent from the modalities under comparison. I think the reason I put this one in here is because even though those images don't indicate a fracture, it's clearly demonstrated by actually looking at the tooth. It's very easy in advanced imaging to assume that the imaging itself provides us with the best characterization of the disease that we've got. And this right here is a nice example because it shows that while modalities can show you features you've never seen before, but which you can see anatomy you've never been able to appreciate in other imaging, it doesn't necessarily mean that it represents the truth. And that's where the problem of bias comes in. In general, it's hard to figure out what your standard of truth is going to be. You'd like to have it to be as close to the real truth as possible. So it would be terrific if you were in a situation where you could do exploratory surgery on every tooth that you imaged so that you could potentially discover what was underneath the image. It would be great to have models like animals or cadavers where you could have control of the acquisition of truth. The problem is that they may differ in some respects from actual living organisms like people. Failing those things, you may want to use histological analysis. All of those are really pretty hard-edged and clearly independent from the imaging modalities under study. Sometimes that kind of information isn't available, though. In practice, we want a standard of truth that is more reliable and valid than the diagnostic imaging that's under study. The three big issues are the reliability of the standard of truth, the likelihood that some of the patients that you want to study are not going to fit within your categories, and the biases that the source of truth can introduce. Long time ago in radiology, George Seeley and the group from Tucson invented a taxonomy of truth information with more reliable standards on one end, working their way through to situations in which you simply ask a group of readers, expert readers, to come to a consensus about what disease is represented or not represented within a case sample. They did experiments which showed that the answers that you get to ordering diagnostic systems may depend on your standard of truth. When you look at the literature over years, you find that, yes, indeed, there are studies out there that utilize samples that can't be generalized to any known population. In general, you want to have large samples. You want samples that get you at least toward what statisticians would consider to be minimally large samples, which starts at about 30 per normal or abnormal. A problem is that in trying to get large samples, experimenters sometimes go for a kind of case that is available, but then doesn't generalize to anything else. It's sort of like the guy looking for his keys underneath the street light, and somebody asks him, where did you lose your keys? Well, over there in the dark, but the light's a lot better here. So that brings us back to here. Assuming that we can agree that gold standards are important, if not always as available as we would like, we then can begin to compute statistics that are mostly ratios that characterize the performance of a system. Sensitivity is very popular, of course. It's the proportion of patients with disease that are called disease present. Specificity, those who don't have disease, who are called as not having disease. False positive fraction goes the other way, as does false negative fraction. Lots of these kinds of fractional values that can be computed. I just put this one in for John, really. The thing about all of these fractions, like particularly sensitivity and specificity. Sensitivity and specificity are sort of, that's kind of the minimally acceptable thing that you put into an article if you want to get it accepted. But there are problems. There are problems with just thinking about sensitivity and specificity. A person named Elmore published a paper in the New England Journal of Medicine, about 15 years ago. And in that article, she tried to characterize the performance of radiologists in reading mammograms. Turns out, she had 10 of them, turns out that their sensitivities ranged from 0.1 to 0.9. And their specificities also ranged from 0.1 to 0.9. And this caused quite a furor in the readership. How can we have people who are so bad and so variable? What's going on here? John Swets and Carl Dorsey published a letter in response in which they plotted the ROC points that correspond to those sensitivities and specificities. We're going to get into ROC curves here in a bit. What they found was that all of the points fit on one single ROC curve. And what that means is that every one of those readers had basically the same diagnostic accuracy. They differed in how willing they were to call cancer. In other words, they were worried in different ways about different sources of error. Some were worried more about missing cancers, and others were worried more about sending women to biopsy who didn't have cancer. There is no unique ROC point, which means when you're reporting a sensitivity and a specificity, it's under certain circumstances. It may be task dependent, it may be reader dependent, but it is not a fixed threshold that's built into the human or built into the imaging system. Here's where we have to bring in a little bit of hardware from the theory of signal detectability. And in this theory, which was developed in the 60s, well, 50s, 60s, and 70s, we assume that we've got two groups of patients, normal patients and abnormal patients, and that they are distributed along an axis of apparent abnormality. Now, this is broadly defined. These could be laboratory values. These could be diagnostic impressions. But in general, we can call this axis apparent abnormality. We assume that the normal patients are distributed in their the appearance of abnormality within whatever test we're interested in studying. And you can see that I've got a Gaussian there. Gaussians are very popular among statisticians, primarily because of the central limit theorem, which says that if you have an outcome that's dependent on a lot of independent processes, and it is the culmination of those things, it's going to tend toward a Gaussian distribution. Lots of things are. Intelligence, height, weight, and apparent abnormality. Now, we're going to get into discussing a bit later whether this is a good assumption or not, but for purposes of explaining the basics, we're going to assume this Gaussian distribution. Next assumption is that the people with disease have more apparent abnormality than those that do not. Not a huge assumption. We're going to also generally assume that there's going to be overlap between these two distributions. Now, instead of there being a fixed threshold for saying that something is abnormal or not, there is a criterion that is going to get used. That's how all of Elmore's radiologists were able to operate at different points, was by moving this threshold. Our familiar decision matrix is going to be represented in here as well. If we have a threshold for calling abnormal, all of those cases where there's disease present and are above the threshold are going to be true positives. All of those in the normal patients above the threshold are going to be false positives. And likewise, we get our true negatives and false negatives. This area right here, over the whole thing, is the sensitivity. And this area here, over the entire distribution, is going to be the specificity. Moving this thing back and forth is going to give you different values. And those values are going to be related. ROC curves. Some of you may already be familiar with them. Here's our Gaussian distributions with normal and abnormal patients. This right here may be best first described as the fraction of false positives. That's our x. The y is the fraction of true positives. If these two distributions overlapped completely, in other words, abnormal cases didn't look any different at all from normal cases, then we would get this line right here. This is often called the chance line. If these distributions were not overlapping at all, or, well, with Gaussian distributions you can't have not overlapping at all, but assume that that this one is, say, over here somewhere, we could put a threshold such that we could end up by getting everything right. We would call all of the people with disease as having disease and all of those without as not having disease. So that's the basic structure of an ROC curve. If we assume that we've got different thresholds, they're going to map onto the space in this way. Basically, each point, each fixed point where we can put a criterion is going to give us a combination of sensitivity and specificity that's going to give us a point on the ROC curve. The points are going to move on the curve depending upon where our threshold is. If we have a very conservative threshold, so that we say to ourselves, well, I've got a lot of overlap, but I don't want to have any false positives at all. Well, I'm going to set my threshold high, and I'm going to be about here. I'm going to have very few false positives and a middling number of true positives. Now, if I move my threshold in such a way that I'm going to allow more false positives, I'm going to get more true positives as well. They are going to increase together, and I'm going to climb up this curve. Finally, if I'm very lenient, I can get in the upper part of the curve. Now there's, as you can see from these two figures, two things going on. We're getting a measure of willingness to respond, which maps onto the same ROC curve, but we're also getting, if we move distributions apart, we're going to get different ROC curve heights. So we started out with the chance line. We get a little bit of separation between the two distributions, and we get an ROC curve that's going to climb. More separation, more climbing, more separation, until we hit this point here where we're doing just perfect. Well, what ROC analysis does is it separates out these two factors. Your willingness to respond, which is sometimes referred to as beta, where you're going to put your threshold, and how separate your distributions are, which is a measure of how well you can discriminate them. Well, before we can go much farther, I have to explain the rating category trick. We had 10 radiologists in Elmore's study, and each one of them had a single ROC point. Each one of them was operating under a different utility matrix, a different set of circumstances that put them at a different place on the curve. Now, this methodology actually came out of audition research. And when they first started doing this, they would have experimental subjects that would sit in echoic chambers listening to tones. And these people were paid very ill. Sometimes they were graduate students. And they could give them a payoff matrix. They could say, okay, every time you make a true positive, we're going to give you a penny. And every time you make a false positive, we're going to take away a penny. But they could change these benefits, so costs and benefits. So they could say, well, we want you to respond very leniently, so we're going to give you $1 every time you get a signal, and we're going to take away a penny every time you make a false positive.
Dr. Berbaum, what do you mean by willingness to respond?
Willingness to move your threshold in different places. For example, suppose I have a payoff matrix where I only win when I make true positives, but I never lose anything if I make false positives. Well, I'm going to call everything. Might as well call them all. So my willingness to respond in that case is very high. I'm willing to make a call. Just like some of the radiologists in Elmore's study were more willing to send people to biopsy than others were. Okay, rating trick. In audition studies where you've got people captured and you can literally run thousands of trials, and you can say, well, okay, we're going to collect this ROC point under this condition, and then in the afternoon we're going to bring you back and collect another one, changing the payoff matrix. It's highly inefficient, and it certainly doesn't work for doctors, which is why people started using rating categories. Rating categories are categories that represent one's certainty in a diagnosis, so that if you are absolutely certain that the finding is there or that a disease is there, we might ask you to represent that by giving a high number. If you're very certain that disease is not there, we ask for a low number. And we might define the in-between points in various ways. We could use things like words like definite, probable, possible, abnormality, suspicious but probably normal, definitely normal. That would give us 5 categories. Some people don't like those kinds of words. They would rather have actual action categories, so that if we were talking mammography, it might be, well, I'm so sure that I'm sending this person to biopsy or surgery. I'm a little less sure, but maybe we should gather more evidence right away, like ultrasound. This looks a little funny. Let's bring them back for screening in 6 months rather than a year, and so on. So if we do that, each one of our points will represent some actual medical action. Others say we need more points, because after all, what we're doing in playing that ROC game is we're taking where we know what's going on, where we actually have points, and trying to extrapolate that to all possible situations of willingness to respond. So basically we're trying to separate out D prime and beta, sometimes called criterion or threshold, willingness to respond, response bias. Thing is, we have to know at this point 2 things. One is that we have to have both sensitivity and specificity to know where we are in the space. If you only have one value, like here, the yellow dots represent the same sensitivities as do the orange ones across these 2. Now, but we've changed the specificities. You can't really know one without the other. Even if that's all you're going to do in your scientific paper, you have to know both. And when I say know, I mean that you have to have the same amount of evidence for both. A very common problem of people trying to do research and report sensitivity and specificity is that they take a sample of interest and they they go to a great deal of trouble getting a good gold standard, and they find out at the end of it that 95% of the cases that they studied had the disease. Well, that's really good from the point of view of specifying what sensitivity is. It gives you a very narrow confidence interval, the space where you're confident that the value lies within. Problem is, if it turns out that you only have, 5 or 6 patients who didn't have the disease that allows you to say what specificity is, then it can range anywhere across the ROC space. Your confidence interval is very wide. So what that means is that your value of sensitivity, so very carefully specified, can lie anywhere along the axis of specificity. So you basically don't know what you got because you don't know where the specificity value is. There's a further dilemma. And the point of showing you these slides is to let you know that we need more than one ROC point. We need more than one value of sensitivity and specificity. Here's a situation where we have an ROC point for 2 modalities, one each. And we put some curves on it. And to put curves on it, we've got to make a lot of assumptions about the shape of those curves.
Professor,
Yes?
what's ROC stand for?
Oh, sorry. Receiver Operating Characteristic. That came out of engineering and psychology laboratories, mostly at Michigan, that were studying signal detection in radar and auditory tasks, largely supported by the military. And so the receiver operating characteristic is where the ROC point falls on the characteristic curve. The language is a little bit esoteric, I admit. Assume we fit curves to these points. We have a situation where modality is better than, B is better than A. If we change the shape of the curve, they could be the same, or changing the curve shape further, it could go the other way. We need more points to define the shape of the curve so that we understand the particular nonlinear trade-off that's being made between sensitivity and specificity. Well, it is worth saying that first we try to fit curves so that first we try to get a lot of points, then we try to put curves fitted to them so that we can understand the sensitivities and specificities that would occur everywhere, not just where we have points. And then we try to discover an index of diagnostic accuracy. Now there's a bunch of these that we could use. Probably the most accessible one is one where we define a level of false positive that we want to characterize all systems according to. In other words, if I say, I only want to have false positive rates of 0.1, I want to be sure that I have specificities of 0.9, then I will look at the sensitivities of my modalities based on that spot. So if I define my reference point as false positive of 0.1, I go up to my curve and I come over and find out what sensitivity it has at that point. So sensitivity at a given level of specificity is a very easy way to think about deriving accuracy measures from these ROC curves. Which brings us to the standard binormal model. The standard binormal model was developed in the 60s. Originally, just like the figures that I've been showing you so far, people used equal variance binormal models, one for the signal and one for the noise. They found that they could have much more flexibility in fitting ROC curve shapes if they allowed for the following model. In this model, we have a Gaussian for the non-diseased, and we assume it has a mean of 0 and a standard deviation of 1, fixed parameters. For abnormal cases, we assume that it has a mu, which can differ from the noise, and a standard deviation. And that gives us two parameters that we fit when we fit curves like this to data. This is the most commonly used tool for 50 years. Anybody see anything wrong with it? Okay, I'll tell you. They cross. This right here creates an anomalous situation because suddenly we've got people with disease seemingly having we have people with disease that look like they're less diseased than normals. And it creates ROC curves that look like this. In other words, they cross the chance line. In general, that's not possible. We don't have any blind radiologists, but if we did, they would be on this line. So crossing it is not so good. And if you're computing area under this curve, which is a very popular way to characterize diagnostic accuracy, instead of the one that I just gave you, you would have troubles because you would be averaging all of this area together, and part of it is obviously wrong. And therein lies the trouble. Now, notice we've got part of our curve here where nobody is operating. Nobody is being that lenient. The problem is that we're fitting distributions to create curves over probability ranges where we don't have any data. And thus we get that impossible event. This has created a decade-long search for models that don't do that. And there are a bunch of them at various stages of development. The data that I just showed you from that ROC curve is from, this is a scout study of an abdomen in preparation for giving contrast. And we did a study in which we compared rating scales. Some people have felt that if you only allow for a much finer grain scale, you're going to get all the points that the subject is not giving you because they have certain predilections. But if I say, well, give me your subjective probability. Give it to me in terms of, well, I'm 5% sure, or I'm 2% sure, or I'm 84% sure, or whatever. You're going to get more points. Well, so we tried this. Here's our rating point scale, 5 points for normal cases, abnormal cases, and here is our longer scale. The strange thing is that it doesn't help. It doesn't help very much at all. We do, in fact, get more points. It's just that those points are in between the coarser points that we had before. And if we fit the data to these more fine points, we still get the hooky thing. Well, what does this mean? Sadly, we came to the conclusion in the 90s that this standard binormal model is not appropriate for radiology data. Continuous data doesn't help, and a proper ROC model is what we need. A proper binormal model, or a proper ROC model, is one which is monotonically decreasing in slope. So we started inventing them. And I'm going to tell you about one that we invented at Iowa. I'm going to tell you about it because I like it. This model was created from a very unusual situation. Had a friend who is a skeletal radiologist, and to do skeletal radiology on ankles, they do three views of a foot or ankle. And they were thinking about getting rid of one of those views because extra views are expensive. If you could get rid of one view on every time you did an exam on somebody's broken or potentially broken ankle, you could save some money. The thing of it is, each of those views is good at seeing different kinds of fractures. Any one view doesn't capture them all. For example, we have a fracture that we can see right here. This is an AP view. AP doesn't mean the same thing for us as it does for you. But there are others that you can't see, which I'll show you. So now we turn it a little bit and we're able to pick up another fracture, which is medial malleolus fracture. We turn it a bit more and create the lateral view, and we're able to see the posterior malleolus fracture. So this person had a hard time. Now, if you plot the data that we collected on these separate views, now this is a little bit of a strange case. What we ultimately wanted to do was combine the views mathematically in order to discover which view we could do without. But if we just stick with the raw data and plot it, we get points that look like that. Now this is a real problem for ROC analysis. Doesn't look like it would be a problem after all. For detecting medial malleolus, obviously the lateral view is worse than the others. Thinking about these things just as imaging modalities, these points are clearly better than these points. And it's true regardless of the observer. But ROC analysis has a lot of difficulty with that because there are a lot of points that have zero false positive rate. And that can give you strange answers. When we move to the posterior malleolus, it gets even weirder because none of the ROC points has a specificity of less than 1. We've got clear differences. Here, the lateral view is the one that really gives you the information about posterior malleolar fracture. But see what our common tools do. This thing right here is the standard binormal model I've been showing you about. PropRock is a proper binormal model that is supposed to be well behaved, comes from Chicago. What these things are telling us is that performance is perfect for all of these conditions. The curve actually goes through 0, 1. Problem is, we don't have any points near 0, 1, so we don't believe that. So we invented a new model. And in this model, there can be invisible signals, sometimes known as occult lesions. That just means that they can't be seen in the imaging. Now, there's lots of examples of pathology that doesn't show up in imaging. Our example from mammography is a very good one. 1 in 5 cancers don't show up in mammograms. Now, we model these invisible signals as being just like noise. There's no more information there for these invisible signals as there is for the normal patients. So now, in general, we assume the area under both this and this to be 1. But so now a portion of the signal is treated as invisible. That gives us curves that depend on some new parameters. One parameter is the mixing. How many visible signals do you have? The other parameter is how obvious are the signals? In other words, how far are the means separated from each other? So let's assume our distributions are far apart and there's no invisible signals. Oops. That'll give us the curve that looks like that. We add in some invisible signals. Suddenly we start getting the same shape curve. It's like line segments, but it's come down to the level of how many visible signals we had. If we got a lot of invisible signals, then it's going to drop way down here. The farther apart the mean is from of the visible signals from the normals, the more angular of a ROC curve we're going to get. As the mu gets smaller and starts approximating a normal situation, we get our familiar curved shape. And the curves that we get then are proper, well-behaved, don't cross the chance line. At the same time, we can accommodate very difficult data like this, where we only have a few interior points to work with. But we can also accommodate data where there are no interior points, only ROC points with specificity equal 1. This gives us some new things to work with. Instead of curves that are demonstrably nutty, we can have curves that are justifiable. Now, this is a third situation that I won't get in too far. Another way of scoring in ROC studies is to take into account location information. You can take into account location information or category information to assist you in getting a more careful scoring. This comes about because sometimes in an image you'll have one abnormality and you know it's there, you proved it, but your observer will call an abnormality, but they'll put it in the wrong place. They'll say, no, you don't have pneumonia, you have heart disease. Now, under standard ROC scoring, we'd have to count that as right. That kind of chafes us a bit because we know that they actually have made a false positive and a false negative. So a way to clean up the scoring is to only give credit if they got the location right or if they got the category right. Now that gives you curves of a different shape. They don't end up at 1, 1 because you can't So even if you called all the cases abnormal, that doesn't mean that you'd get the locations right. As far as fitting data, we checked some classic data sets. This one is a really classic data set. This is probably the Sweats, Pickett, and Company from '79 science paper was probably the first really well done comparison of diagnostic systems. Turns out that our new model fits the data better than the standard method, and this one is another proper model that we invented, which isn't a bad model either. But we can see this data is from a computer aid to diagnosis study, and it's in mammography. So we didn't find it at all surprising that we fit the data well, because we can account for all those invisible cancers. Well, the story that I've been telling you, it's a good story. I think it's a good story. Scientifically, I don't know how interesting it is, but it doesn't mean that while I know how to do ROC analysis really well, and so do a number of other people like Charlie Metz or Dave Chakraborty or several other guys at the FDA, or that doesn't mean that proper curves are always going to be used in print. This right here is some data from the New England Journal, 2005. This was a comparison of film and digital mammography. This was the so-called DMIS trial, where they imaged 46,000 women and found 200 cancers. And their conclusions were that for older women, it didn't make as much difference as for younger women. Here are our curves for digital and for film. That looks like a nice difference, doesn't it? Although, a couple things that we should notice. We've got a hook, don't we? That's because the methodology that they used to compare their modalities ignores reader effects, is specifically developed for comparing pairs, but is basically the standard binormal model. Also, we notice that our categories are all in the lower left side. Our ROC points are over here. We don't have any here. One of the really nice things about the contaminated binormal model is that it predicts that that's going to happen. It predicts it because that having visible signals, invisible signals, and noise, but very far apart. In other words, when they're visible, they're very visible. That means that there's this broad area where you can slip a decision threshold, and you're going to be able to move it quite a bit. You're going to still get the same data in the categories. And there's no reason to move, well, there's no reason to move the threshold higher only on the signal curve. You're just losing true positives. And there's no reason to move it lower across these overlapping noise and invisible signal distributions, because you're just walking up a chance line. That tells you that your points are all going to be in the same place. Two things happen with proper models. You tend to get mean differences between conditions. that are somewhat smaller because you're not adding in any noise from the parts of the curve where you don't have data. But the standard error, the mean difference, gets smaller, the correlations between conditions get higher, and you get higher levels of significance. What I've been telling you about so far is only part of the story. I mean, getting ROC curves and getting measures of accuracy from them means that you're getting good measures. But it doesn't tell you about generalizing to populations. There are I told you that there's two ways of improving diagnostic accuracy, one by improving imaging and one by improving the interpretive process itself. In the first of those, the basic unit of sampling is the patient. The way you want to generalize is to all the patients from the sample of patients that you have gathered. If, on the other hand, you're trying to understand the interpretive process, and there aren't that many people who do that, I'm one, so it comes up for me quite a lot. Instead, you want to generalize to the population of radiologists. And in either case, you may be treating the odd variable as a nuisance factor. So if I'm going to do a study of, let me think, what? Maybe X-rays of teeth or cone beam CT of teeth. My main sample is going to be patients. It's going to be, now I could change what I think of as the unit of sampling. It could be patients, it could be teeth, it could be sections of teeth. But in general, those are all patient issues. They're not radiologist issues. And so when people do studies aimed at that, they tend to focus on that area of sampling. Now, they may add in more than one reader. They do that to increase statistical power because there are methods wherein you can take into account the data from more than one reader and get more and more statistical power. I am explain what power is, I know. That's the ability to find a difference between modalities if one exists. For my work, though, I don't always work with a sample of patients. I work with a set of patients that usually have some peculiarity, and I show them to groups of radiologists. And now sampling depends on how many of those people we can get. We developed a methodology about 1992 that basically recognized that there were these two directions of generalization. ROC analysis is very inefficient because it takes the data from many patients and it turns it into one number. So that to do those ROC curves, maybe I had 100 patients that had no disease and 100 patients that did. I played my ROC analysis game and I got one number. I got a sensitivity and a sensitivity at a given specificity, or I got the area under the curve, but I got one number. From a statistical power point of view, that's terrible. That's like instead of having a lot of data, I have very little data. So we used a resampling method, jackknife, that could essentially get back all that power for us. Then we use standard statistical analysis. Now we can focus on one or the other type of generalization doing it, or we can do both. We can generalize. We can have experiments that generalize both to the population of patients and to readers with added statistical power.